السلام عليكم، يعطيكم العافية أراك. اليوم إن شاء الله رح نشرح المحاضرة الثانية من البروستة. تمام؟ بسم الله الرحمن الرحيم. So in today's lecture we are going to talk about the anatomical landmark and the area of the edentulous maxilla. So we know that we have a maxilla and mandible, right? Okay, and we defined the meaning of edentulous in the last lecture, and we said an edentulous is the patient that he lost all of his teeth, يعني حتى واحد it's not remaining. Okay, and now in this lecture we are going to talk about the anatomical landmarks. طب شو يعني anatomical landmarks؟ يعني we will have certain area or certain things okay, that will give us like a sign or a map how the jaw was before the patient lost his teeth. okay, يعني زي هي تعطيني زي يعني كيف انت ماشي بشارع فاضي فانه بتلاقي مثلا اشاره انه هون في عندي مثلا صخره، فهون مثلا كذا، هون كذا، هون كذا. like this we are going to talk about the landmark of the edentulous maxilla. تمام. المهم, so now the complete denture, as we said in the last lecture, in this semester we are focusing on complete denture, removable complete denture of course, and it restores the missing structure which are bone, soft tissue and teeth. And we said that when we say removable, we know that the removable part of a prostate replaces not only the teeth but also the surrounding, right? Come on. So what's the purpose of making a complete denture? So the purpose of making a complete denture is restoring the aesthetic, as I said, aesthetic هي appearance, so الجمالية يعني, and to restore the function. And we said before that the function is not only eating, it's also what? Eating and speaking and so on. And the occlusion with the contact between the upper and the lower teeth and the occlusion. Okay, so these are the purpose why we make a complete denture. So to achieve this purpose we have to follow some principles. Okay, the principles اللي عنا إياهم هنا retention, support and stability, and now we will talk about them in details, the three terms these. Okay, so we have to fulfill these three principles. Like as we can see in this picture that the purposes or حتى the principles, they are overlapping, right? They overlapping together هون بالمدى. So sometimes when we want to مثلا we want to achieve this purpose اللي هو occlusion. Okay, when we achieve the occlusion the function will be achieved, right? The function won't be achieved without the occlusion لأنه if I don't have contact between the upper and lower teeth, how you are gonna eat, right? So also when I achieve the occlusion I will have aesthetic because the teeth will occlude in specific areas إلى آخره, aesthetic. Okay, إلى آخره. So they are interrelated. Also the principles here are interrelated, so they are overlapping. So this principle overlap, which means one factor that contribute, for example, for retention, also contribute for support, stability إلى آخره. Okay, now also they overlap. Also you have to know that the relation between the principles and the purpose or the goals is reciprocal. It's يعني work on either side in both way. So in order to achieve a successful denture it have to fulfill these purposes and also it has to fulfill these principles. تمام. Now talking about these principles we will start with the first word, which is retention. What is retention? Retention is the ability of the denture to resist the forces disabling the denture in any direction and opposite to his path of insertion. Oh, okay. First of all, we are going to divide this definition so we can understand it. So, what's the meaning of path of insertion? The path of insertion is the path that the patient used to wear the denture. يعني هو الطريق اللي أنا راح ألبس الدنشر عليه. So for example, if this is mandible, so this is your mandible, whatever. This is the mandible, and now you want to wear the denture. So the patient will put the denture like this. So this is the path, the insertion is how the patient wear the denture. Okay, some people will say انه اوكي دكتورة اكيد دايما راح نلبس الدنشر بهالشكل يعني بالpath of insertion. No, sometimes some patient will wear the denture in oblique way, يعني like this they will wear it. Okay, and they will wear it like this. Some people maybe will wear it in oblique direction, then like this. Okay, however the path that is taken by the patient to wear the denture is called the path of insertion. Now for example, if we said that the path of insertion is like this, تمام, so any force like so, any force that displace, that will remove يعني the denture in direction opposite to the path of insertion, this is the force that will مثلا remove the denture from its place. Now if I resist this force, if I resist it, this causes retention. This causes retention. يعني for example, if I have the maxilla, this is the maxilla, and we have the force that will make the denture fall, that will displace it, هي مثلا the gravity, right? So resisting this force, resistance is called the retention. Okay, so أنا بحكيها بsimple word، هي مقاومة الدنشر إنه يوقع، بس إنه بيقاوم إنه يوقع، إنه ما يوقع، بس ببساطة. Look at this picture here. She blow and then the denture fell down. So there is no retention. الطقم تبعها is not resisting the displacing force. So هون there is no retention. We want to achieve a retention with our denture, because when you achieve the retention, as we can see here, when you achieve the retention, you will give the patient psychological comfort. شي يعني تخيلوا, imagine now that we have a مثلا an actor, okay, or a speaker مثلا اللي هو مثلا a doctor عم بيعطي lecture, okay, he is wearing a denture. If the denture is not retented in its place, when he is talking the denture will fall. أو تخيلوا هو ممثل actor while he is يعني acting the denture fall, so that will not give him the psychological نفسيا comfort. Okay, تمام. So هو بكل بساطة the resistance of the denture to fall. بس يعني in simple words it's the ability to the denture to resist being fall, إنه fall. هلا as we said بالماكسيلا the force that can make it fall هي gravity. بالماندبل طيب what is the force that will work opposite to the path of the denture؟ ممكن sticky food. ممكن sticky food will dislodge it. So as we said the retention it will work against the path of insertion. So force will work against the path of insertion. I want to resist that force. So when you insert the denture inside your mouth, we insert it over the alveolar ridge, and then we push it down. This is the path of insertion, is the direction is represented by the white arrow here in this picture, okay, perpendicular to the supporting structure. It's not always perpendicular, whatever. The forces that is opposite, هي forces are displacing force, صح? It's taking it from its place, like مثلا sticky food. So the ability of the denture to resist this blue forces are retention, okay? تمام. هلا the second word will be support. هلا support is the ability of the denture to resist the tissue-ward movement. Okay, the tissue-ward. هون في عنا along the path of insertion. So now the forces are along the path of insertion. For as we said, the path of insertion like this. Now we will have some forces that will press the denture down. We want to resist these forces that is pressing the denture down. أنا بحكيها بsimple word هي إنه ما أخلي الدنشر يغوص. تعرفوا البين باج لو نطيتوا عليها زي هيك شو بتصير بالبين باج؟ بتغوص صح؟ So I want to resist the denture from being هيك pushed down or إنه يغوص. Okay, a tissue ward movement, because I want this tissue to give me support. I want the denture to sit on them, not to dive inside them. Okay. So like when the patient is biting on the denture, so biting forces, the denture will be pushed, طبعا push هيك, okay, the denture toward the tissue. فهون I want to resist these forces that is pushing the denture toward the tissue. هلا آخر كلمة اللي هي stability. The stability, it is the ability of the denture to resist the dislodgement force. هلا all of the three terms is ability of the denture to resist, is the ability of the denture to resist, but the force, the direction of the force is different. Like هون it's the ability of the denture to resist the forces. It's the ability of the denture to resist forces that is displacing in the direction opposite. هون as we said against the path of insertion. الكلمة الثانية اللي هي ability of the denture to resist هون forces that is tissue-ward اللي هي حكينا along the path of insertion. Okay, similar to the path of insertion. هون stability, ability of denture to resist of which forces هون they are not parallel to the path, not parallel. لكن كيف بيكونوا lateral يعني جايين هيك وهيك. Okay, lateral forces. هون the ability to resist this lateral or sideway movement. Okay, so if you are wearing a denture, like for example this is the mandible, and you are wearing a denture like this above it. Okay, So I don't want my denture to rock. يعني ما بدي أتحرك يمين ويسار to rock. Okay, to move like this. I don't want my denture to rock. لا, okay. فهاي rocking movement. Okay. So محمد, it's the stability. يعني resisting it is the stability. تمام. As we can see, retention against the path of insertion, it's up, support toward with the path of insertion, and the stability, it's not parallel. هيك يعني different axes. Okay. تمام. هلا when we achieve the support that we talked about before, it's related to the longevity. ايش دخل support بالlongevity? What's the relation يعني؟ هلا as we know that the bone, as we said in the lecture, it doesn't stop from يعني resorbing. عملية resorption تبع البون is continuous, it never stops, right? So when I wear a denture, the denture will never or will not stop the bone from resorption. Okay, so when the bone resorb and resorb, that means that this denture will not fit. Okay, يعني لما يضل البون يدوب هذا الدنشر نفسه ما بقدر أضل ألبسه. For example, like مثلا if you buy a trouser ولا shirt ولا dress ولا أي شيء, مثلا if you wear a dress, okay, and you are getting bigger and bigger and bigger, when you get bigger the dress will not fit you. Okay, نفس الشيء الدنشر, same as the denture. Okay, يعني denture work in a similar way. When the bone resorb and resorb, the denture will not fit because the يعني with the alveolar ridge it changed. Okay, so because of that it supports. هلا when the denture resists when the denture resists the forces that will move the denture toward the tissue, okay, it will stay long time. okay, يعني رح يضل موجود عندي وقت أطول. it will stay for a longer time. if it doesn't resist high forces, تخيلوا إنه هذا الطعم ما بيقاوم, it doesn't resist the forces that will push them down, so it will apply forces and this bone will resorb more and more, so I will have to replace the denture faster. okay, فعشان هيك له علاقة بالlongevity. يا رب تكون وصلت. يعني أنا مثلا عندي هذا الماندبل, تمام, وفي عندي هون الطقم. Okay, let's imagine that this denture will not resist the forces, so it will push down and push down and push down. So the mandible, what will happen to it? It will resorb more and more. So I have to change this denture faster. Maybe 1-2 years I will change it. But if the denture will resist these forces, is the denture it will resist, maybe this denture will last for 5 to 10 years like this. Okay. So, for the stability, if the denture is stable, what will happen? It will give the patient the psychological comfort, يعني the ability to eat, the ability to speak. لأنه تخيل إنه أنت imagine like you are eating and there is something in your mouth moving left and right. So you won't be able to eat. Okay, so it has to be stable. If I achieve these three things, and if I achieve the stability, the retention, the support, the psychological and physiological and longevity, then I will reach the success. Okay, so achieving this principle will give me the success of my treatment. تمام. هلا نترك هدول الكلمات ونروح هون عن نحكي عن الدنشر bearing surface. شو يعني الدنشر bearing surface? It's the surface that is in contact with the denture. Okay, يعني for example, this is the denture. Now the surface that is underneath it is the surface bearing that is with contact with the denture. Okay, like in this picture, where is the surface that is with contact with the denture? It's this surface. هاي tiny surface on the surface. As we say surface يعني السطح, outer surface. هاي هي الdenture bearing area. Okay, which is the part of the mucosa, right? So a denture contact mucosa, right, with a continuum of compressibility and movement that vary between each arch among area within the arch and among patient. Now, okay, when the denture contact the mucosa, it will compress it, right? رح تضغط عليها, it will compress it. Now the compressibility and the movement, and طبعا we said before that this is a removable denture. Because it is removable, you have to know that it will move. But we will try to make this movement as minimum as we can, but it will never reach zero. Okay, يعني لأنه الطائم متحرك, من اسمه متحرك يعني رح يتحرك, بس نحن بنحاول قدر الإمكان نخلي حركته كتير قليلة, بس عمرها ما رح توصل الصفر, بس بنحاول. Okay, تمام. So the compressibility and the movement will vary between each arch يعني maxilla mandible upper or lower within the arch itself anterior or posterior among patient from patient to another. Okay. طيب depending on what يعني هاي compressibility will change according to what? It will change according to the يعني الميوكوزا نفسها according to the mucosa itself. Okay, the compressibility and the movement it will varies according to the structure of the mucosa itself. Okay, so let's look at this picture. It's a sagittal section. انتم بتعرفوا في عنا coronal, sagittal إلى آخره. This is a sagittal section. تمام. And we are looking to the maxilla. You can see that it fits over the denture is fitting over the maxilla like a glove on your hands. Okay, it's fitting on it. Okay, it's making contact. تمام. As we said, the different compressibility depend on the different histological structure of the tissue. It's the different histology of the mucosa. So the compressibility will vary according to the different histology of the structure. تمام. So شو يعني compressibility? What's the meaning of compress? إذا أنا قلت لكم اضغط بالون, compress a balloon. What's the meaning of compress? It's squeezing something, right? It's squeezing something. Like if this is a balloon, squeezing it, it's compressibility. تمام. تمام. هلا the degree of compressibility over the residual it's different on the hard palate, soft palate, so we need to take consideration. As we said within, and each area will have different compressibility. The upper different than the lower, a patient different than another patient. Okay. تمام. هلا the short term and the long term health of the contact tissue is influenced by the method used by capture these tissue and final adaptation. Now, the health of this tissue, it will depend on the compressibility, okay, of the adaptation and how this denture fit or sit on the mucosa. The health will differ. For example, look at this picture. تمام. If the denture هلا إذا كان الدنشر قاعد وضاغط كتير, if it's squeezing a lot, كتير squeezing, what will happen to the mucosa? It will damage, okay? It will irritate. It will, as we say, inflamed, become inflamed, okay? So the health, it depends on the compressibility والadaptation, how it's fit, كيف هو قاعد, okay? تمام. هلا how we can decrease this compressibility or how we can decrease this pressure, how we can decrease these forces. Okay, we can decrease it by increasing the surface area. You know بالphysics pressure تساوي force on the surface area, right? So if we increase the surface area, the pressure will be decreased. Okay, so if we extend the denture base, we increase the extension, the surface area will increase, so the pressure will decrease because the force will be spreaded. As you can see on this picture, if I have this surface area and I apply the force on it like this, but if I increase the surface area, so the force will be what? Distributed, will be spreaded, so the pressure will decrease. Okay, so we need to maximize, as I said, the tissue coverage as much as we can to reduce the pressure. Okay. تمام. So if we decrease the pressure, then we protect this tissue from inflammation or irritation or إلى آخره. Okay. تمام. هلا now the denture bearing area يعني فينا نحكي ال general word is the denture bearing area. So the denture bearing area it's classified or composed of two areas: the stress bearing or supporting and the peripheral, which is the limiting. Okay. So bearing area, so the denture bearing area is classified in your supporting area or stress bearing area and the limited and peripheral area. So now we are going to talk about first the supporting. So هلا نحن رح نحكي عن supporting structure أو supporting area أو stress bearing area. Okay, رح نحكي عن stress هون bearing. Okay. تمام. So هلا بحكي لك the foundation for a denture. We know that the foundation of the denture يعني beneath the denture we will have bone, صح? That will give us support. It will prevent, as I said, the denture from sinking, from diving in. So, and this bone is covered by soft tissue, which is the mucosa. And this will give us support. The principle that we talked about before is preventing the denture from moving toward the tissue. تمام? So we will have mucosa, and under the mucosa we will have bone. تمام. So the denture base rests on the mucosa, right? The denture will sit on the mucosa like this. The denture will sit on the mucosa, which serve the cushion. It's like a cushion between the denture and the bone, صح؟ يعني imagine if you are sitting, أنا قاعدة على كرسي made of wood, or I'm sitting on a chair but it's made of مثلا sponge or made of high. Okay, which one will be more comfortable? Which will give me like a cushion? Of course, the one made of sponge. So the denture, when it's set, it doesn't sit on the bone directly. It's set on the mucosa, and the mucosa it's like a sandwich, صح؟ الميكوزا محصورة هون like a sandwich. هذا البون وهاي الميوكوزا, and this is the mucosa covering the bone, and هلا نحن في عنا the denture will come above it. So the mucosa is like sandwich, giving me the cushion effect. Okay, so we need to reduce the stress, as I said before, to reduce the load, to reduce the pressure load, on the mucosa. Otherwise, if the load is too much and the pressure is too much, it's going to be what? Crushed. It's like a sandwich. It's going to be crushed. Okay, and if it's crushed, what will happen, as we see in the left picture, is going to inflame, swollen, irritate, okay, whatever. And the hard material of the denture base and the bone will cause pain and ulcer of the patient, okay? So if it is crushed, if the pressure is a lot, it will crush and it will hit the bone, or it will, load will transform to the bone, causing pain and ulcer and إلى آخره, okay? Now, furthermore, the supporting structure is divided to primary supporting structure and secondary. So, if we want to draw like a map, خلينا هون. Okay, we will say that the bearing area are classified into stress bearing area or supporting, which is called supporting, and we have the peripheral area. Peripheral area, which are going limiting, okay, limiting area. Now, also the supporting structure or stress bearing area are classified into primary supporting area and secondary. Okay? So, what's the difference between the primary and the secondary? Of course, they are divided by histology. So the histology divide them. So the primary stress bearing area, they tolerate more load than the secondary. More load is tolerated. Why? And they are not easily traumatized, not easily causing ulcer. Okay? Why? Because one, they have thicker mucosa. Two, the bone of them are made of cortical bone. Okay, so they are made of thicker mucosa, and the bone of it's cortical, and add to them also the mucosa is keratinized, and it's made of keratinized mucosa. So you can add, it has thicker mucosa, 1 2 cortical bone 3 the mucosa is keratinized. Okay, مو شرط دايما تكون keratinized, يعني not always it is keratinized, but it's one of the reason that will make it primary. Okay, example, let's take like now in the maxilla, the primary stress bearing area are the hard palate and the tuberosity. You know what's the hard palate, as you can see in the picture on the left. This is the hard palate, right? This is the palate, so the part here, it's the hard palate, and the tuberosity, هذا الهارد palate, as you can see in the picture on the left. تمام, and the tuberosity, هاي the tuberosity. Okay, this is the tuberosity. We will talk about them in details, but now I want you just to imagine, so we can flow الانفورميشن كان flow easily. اوكي, عشان هيك انا بدي اياكم تتخيلوا من هلا انا شو عم بحكي قبل ونحكي عنهم details لقدام. تمام. So this is the tuberosity, as we can see. تمام. So these two parts, the hard palate with tuberosity, are primary stress area. Why? Because the bone is cortical and the mucosa is thick. تمام. تمام. هلا in the mandible it is the buccal shelf area. This is the buccal shelf area. تمام. And هاي الbuccal shelf area اللي شايفينها بالصورة, and the retromolar pad. As you can see in the picture, this is the retromolar pad. تمام. Okay. هلا note firm tuberosity, primary supporting. Sometimes the tuberosity are fibrous. Look at this picture. No, wait. sometimes like this the tuberosity بيكونوا fibrous يعني معمولين من fiber. Okay, so if they are fibrous they will be soft, they won't be firm. Okay, رح يكونوا soft. If they are soft they are not so okay and enlarged, so we classify as secondary. They won't be primary, they will become secondary because they lost the ability to withstand the load. Okay, so they have to be firm. Less secondary stress bearing area, as we said, they are less durable, they less tolerate, less withstanding, they will less withstand the load. They are made of not cortical bone, of spongy bone أو اللي هو الcancellous bone, and the mucosa will be thinner. For example, in the maxilla it is the alveolar ridge, you know the alveolar ridge صح؟ والruga area, هاي هي الruga area, this is the ruga area. So the ruga area and the alveolar ridge. In the mandible it's the alveolar ridge. Okay? So as we can say, look at this. يعني هذا diagram. It's summarize what we have said. In the maxilla, the tuberosity and the heart palate, it's what? It's primary. And the alveolar ridge والruga, it's secondary. بالmandible, buccal shelf retro, it's the primary and secondary is the alveolar ridge. Okay. تمام. هلا بدي اياكم تحطوا بعين الاعتبار something I want to take into consideration something يعني إنه the مين main, which one of them, it's the main primary stress bearing area in the maxilla. The main is the heart palate because as we said sometimes the tuberosity become fibrous, so the main is the heart palate. And the mandible, which one of the main? المين هي buccal shelf area. Why the buccal shelf area? Because the retromolar palate sometimes it's يعني ما بتكون موجودة, it's not there. Why it's not there? Because when you extract the third molar it forms a retromolar part, so sometimes it's not available. Okay, so the main, it's the buccal shelf area. تمام. Moving on, now we'll talk about histology. المهم, so the histology, now we know that بدي رسمة مقطعية هون. Look at this picture. We have the oral mucosa and then the submucosa وبعدين عندنا bone. So we have, this is the oral mucosa. So this is the mucosa, كل هاي mucosa. Then we have submucosa, then we have the bone. Okay, so these are the layers. So بيكون في عنا mucosa, then submucosa, then bone. Now, what is the mucosa made from? The mucosa طلع, it's made from epithelium, which is stratified squamous epithelium, yeah, squamous. So we, as this picture on the left, so in mucosa, this is the layers of the mucosa. So it's made of stratified squamous epithelial cell, and it's made of lamina propria. طب شو هي lamina propria? What is the lamina propria? It's loose connective tissue. It's loose connective tissue. تمام, so it's a loose connective tissue in the mucosa. وين اللامينا propria قاعدة? In the mucosa. Be careful. Okay, فهاي هي the layers. It's made of epithelium and lamina propria. Now the submucosa, هاي هي submucosa, it's made of connective tissue. So the lamina propria and the submucosa are made of connective tissue, but the difference that the lamina propria, it's in the mucosa and it's made of loose connective tissue, but the connective tissue in the submucosa is denser and the place of it's يعني submucosa. هلا submucosa, it give me the support for the mucosa. It provide the support for the mucosa. تمام? It support the mucosa because it has dense connective tissue. It have fibrous connective tissue. Okay, and underneath it we have the bone. تمام, نرجع لفوق هون زي ما حكينا. So we have the mucosa of epithelium and lamina propria, and the submucosa it's have connective tissue, and the connective tissue character it's vary from dense to loose areolar tissue, and it change in thickness. بيهمنا thickness, very important. Okay, يهمني thickness. It will provide the support, as I would say. It will provide the resilience, the ability to withstand the load without damage. So the mucosa or the submucosa will provide the support or provide me the withstanding or the resilience. The submucosa هي اللي رح توفر لي هاي الأشياء. تمام. So imagine if we have no submucosa. So there is no support, there is no withstanding, there is no cushion. So the tissue are not resilient. so it will be crushed and damaged and irritant إلى آخره. Like this picture. Look at this picture. We don't have submucosa. We only have mucosa. This is whole is a mucosa. There is no submucosa. It's made of epithelium. Lamina propria. There is no submucosa. ها وفي bone. High bone. Okay. In this situation, like if we compare this A and this B, A will give me cushion, will give me resilience, will give me support. It will stand load more. There will not be damage or irritation وإلى آخره. In B, no, it won't give me tolerance. It won't give me resilience. It won't give me withstanding. So more damage will happen and إلى آخره. Okay, so it depends. It depends on having a submucosa or not. Okay, if this submucosa is thick or thin, تمام. And as we said, the bone, if this cortical or not, so it's depend on this. Okay. هلا نحكي عن residual ridge mucosa. So we are going to talk about the residual ridge. Okay. So as we said, now we are talking about. So to recap, we are talking about the stress or supporting area, right? We said that there is primary and secondary. Primary and secondary. Now we are talking about the secondary, which is the residual ridge. Okay, so the residual ridge. We are going to talk about them. So, a residual ridge, the mucosa that is covering the residual ridge is keratinized. هلا as we talk in histology أو زي ما أخذته بالبيريا, we said that the mucosa that is keratinized, it's where it exists in two places, right? It exists in the gingiva زائد الهارت palate, صح? Only in the gingiva and heart palate. تمام. So now when we extract the tooth, okay? So when you extract the tooth, this remaining part of the gingiva, this remaining part of the attached gingiva, after extraction, it will cover the ridge and it will make the ridge keratinized, okay? So if the mucosa is keratinized, it will be more capable to withstand the load, okay? After extraction, keratinized tissue will be on the crest, on the ridge and halfway of the buccal and lingual slopes. What's the meaning of that? تخيل if this, I have a tooth here, this is a tooth, and it's here we have the gingiva, okay? Now if I extracted this tooth, like this, then the gingiva will close, right? So if the gingiva closed like this, so I will have here keratinized tissue and on the slopes, but not all the way, بس halfway into the slopes, buccal and lingual, halfway. This part will be keratinized on the crest of the ridge and halfway buccal and lingual, the keratinized tissue will be. تمام? And we said the keratinized tissue, they are in oral cavity بالgingiva والpalates only. تمام? تمام. So, as we said before, if you want to know if this tissue will withstand the forces or not, we are going to look about, on واحد البون. We will look at the submucosa if it's thick or thin. The submucosa, and we are going to look at if it is keratinized or not. تمام؟ So الريزيدوال ridge أستاذ محمد الميكوزا اللي فيه it is keratinized now, okay? So بقول لك that's why when you extract a tooth you have to pay attention to the available gingiva إلى آخره. So on the crest of the ridge we will have the mucosa is firmly attached to the periosteum. Now so هلا إحنا حكينا رح نقارن بثلاث شغلات صح؟ 1 البون، 2 السبميوكوزا، و3 keratinized. Now, a residual ridge, it is keratinized. True. So it is keratinized. But, look here, the mucosa, it's firmly attached to the periosteum. There is no submucosa. So submucosa, no. Okay? By the connective tissue of the horn. Is firmly attached to the periosteum by the connective tissue of the submucosa. It's firmly attached. After the extraction, bone will start to resorb, and the greater bone resorption lead to. Okay, let's leave this شوي كمان. So now we said that the residual ridge mucosa, it's not thick. So submucosa, it is thin, and the bone here is spongy. So because if the bone is spongy and the submucosa is thin, we classified the residual ridge as secondary stress bearing area, as a secondary. تمام? So that's why we don't depend on the keratinized alone. We have to look at the bone and submucosa. وصلت؟ يعني هون أنا بقارن 3 شغلات. بشوف البون هل هو spongy ولا لا. بحالة الريزيدوال ريتش it's spongy. طلع لي submucosa هل هو thin ولا thick. بحالة الريزيدوال it's thin. keratinized صح بس keratinized لحالها it's not enough. Only keratinized alone it's not enough. We have to look at the bone and submucosa. Because the bone is spongy and submucosa is thin, so the residual rays is classified as secondary stress bearing area. تمام؟ تمام. هلا as we said the resorption of the bone won't stop. It's a continuous process. So هلا when the bone resorb and resorb and resorb, what will happen? The mucosa will be thicker and thicker and thicker. So the mucosa will become loose. So the mucosa will become loosely attached to the underlying bone and will become movable, displaceable. Okay? So that's why also it will be traumatized. يعني شو معنى هذا الحكي؟ We said that we want thick mucosa. بس كمان أنا بدي حل وسط. ما بدي إياها يا طخة يا أكسر مخها. بدي إياها حل وسط. ما بدي إياها I don't want it to be too thick because if it is too thick it will become displaceable. It's become movable. It will become loose. And if it was thin also it will be traumatized because it won't شو اسمه withstand the forces. So I don't want it very thick. And I don't want it to be thin. I want it to be just thick. Okay? So let's imagine this مثلا scenario. I have A and we have B why A وعندنا C. In the C we have the submucosa is too thick and then we have the bone underneath it. Okay? Now in this situation as we said before in B, because there is no submucosa, it won't withstand the forces. In C, because the submucosa is too thick, it will be displaceable. You know what's displaceable. يعني فيك تمسكها وتحركها يمين ويسار. هاي معناها displaceable. You can move it displaceable. So also I don't want it like this. I want it like this, thick. تمام? We will take in 4th year السنة الجاي رح تاخدوا إنه if the mucosa were يعني very thick and displaceable, what you are going to do. There is a specific method that we use it. Okay. Now, so the greater the bone resorption, it will lead to increase the tissue compressibility and displaceability. So the denture will be unfavorable or not desirable. Okay. So like, what's the difference between compressible and displaceable? Compressor, يعني I can squeeze it toward the alveolar ridge. يعني you can squeeze it or compress it or press it in this direction. Displaceable, it means you can move it sideways. You can move it like this and like this, okay? And both of them, and the compressible, very compressible, and the displaceable is not desirable for the denture. It's not desirable, okay, for the denture. تمام. Okay, and as we said here, when the submucosa is thin, it will be less resilient, it will be easily traumatized, it needs relief. We will talk about what's the meaning of relief. Okay, when the submucosa is loosely attached or inflamed. Also, when the submucosa is loosely attached, when you hear loosely attached, mean very thick. So if the submucosa is very thick or inflamed, you know when an inflammation happens, it will become swollen. So swollen, also very thick. So it will become more displaceable and compressible. And so we don't want like this, okay? So don't want it like this or like this, okay? Now, what's the concept of relief? The concept of relief that the area on the fitting surface of the denture is reduced to eliminate the pressure on it. يعني, as we said, this is the مثلا the mandible and this is the denture above it. Okay, now what will happen in relief mean من اسمها relief to relax, right? So I'm going to what? To reduce the pressure. For example, I want to reduce the pressure on this spot. So I have to eliminate the pressure on it. So I will reduce the pressure on this. This is called relief. How we are going to relieve or to reduce the pressure on it? By creating a space. So for example, this is the denture. I will create a space for this, like this. I will create a space for it. This is called relief. Simply as this. So simply it's to provide a space between the denture surface and the tissue. So we have a space. تمام? Okay, so we have certain areas in in the mouth that we have to relieve it. Okay, what are these certain areas? For example, we have the palatal torus. What is the palatal torus? This is a palatal torus. It's like an extra bone in the palate, so we have to relieve it. We have the median palatine raphe. You know what's the median palatine raphe? This is the median palatine raphe. It's the line that is going in the middle للheart بنت. هذا الخط الماشي بالنص هي الميديان palatine raphe. We have the mandibular tori. It's extra bone in the mandible. We have the retromylohyoid ridge. It's like, this is the retromylohyoid ridge. It's like a ridge. It's extra bone يعني طالع هيك. أي إشي بارز. So أي bone that it's look extra, that's look bulgy, we have to relieve it. This is bone look bulgy, right? This bone, of course, bulgy. This bone, it's bulgy. So we have to relieve them, okay? Mid palatine raphe is fiber. So raphe is made of fiber, but these fiber are sensitive, so we have to relieve them. Also, we have the incisive papilla. You know the incisive papilla in this picture. High incisive. It contains nerves. It contains blood vessels, so we have to relieve them. Okay, undercut or bony sharp prominence. As I said, any bony prominence, any bulgy things, we have to relieve them. Also, anything that contain fibers and nerves, we have also to relieve them. Okay. So I'll now continue talking about the mucous membrane. So as the mucous membrane extends from the crest along the slopes of the residual rest to the vestibule reflection, we know the mucosa, it extends from the crest, this is مثلا the crest of the ridge, until the reflection of the vestibule. You know what's the reflection of vestibule, right? This is the reflection of the vestibule. هون between these two lines, هاي هي reflection of the vestibule. هاي هي vestibule. This is the vestibule. So it's extend all the way of it, okay? تمام, and it's attached to the bone. هلا moving from here, it will be firmly attached to the underlying bone, but moving from the crest to the vestibule, it will lose this firmly attached, okay? It will lose. And as we said, here we will have keratinized mucosa, but moving down, it won't be keratinized, okay? The more loosely the attached it will be non-keratinized. As I said, it will not be keratinized, or slightly. And the submucosa also will contain loose connective tissue. So in this area, up in the crest, like this, up on the crest, we will have keratinized mucosa, and it's firmly attached on, and the connective tissue is dense. But moving down to the vestibule, the mucosa won't be keratinized. It won't be attached firmly to the bone, and the connective tissue will be loose. So these tissue that are down here, they don't withstand the forces of mastication. تمام? As the mucosa that's here will withstand. Okay? بس هاي الفزلة اللي بحكوها هون. تمام. Now, moving to the we are also still talking about the residual alveolar ridge. Now, the residual alveolar ridge, when we say residual, شو يعني residual? It's called هلا before the extraction, it's called alveolar ridge. Before the extraction. After the extraction, it's called residual. So what is residual? So what have still there? Okay, يعني شو الاشي what's still there? Okay, يعني after the extraction, what we have now is the residual. What has been يعني شو اللي ضل عندي? What has been and resides after extraction? شو ضل عندي? Okay, so it is the raised area when extracting a teeth. Okay, so it's the raised area when extracting a teeth. هلا it vary in size and its shapes. Look at this picture. It can be like V shape, it can be like square shape, it can be like round shape, okay? So it's vary. تمام. So after extracting the teeth, the width and the height of the residual ridge will change. Resorption will happen. We say resorption will happen. The resorption in the first 6 to 12 months will be the greatest, will be the fastest, okay? But then it will continue it will reduce the rate, راح يصير أقل, okay? So as we said, the ridge is secondary supporting area. The lateral wall of the ridge بتعطيني stability against the dental lateral displacement. It will give me the stability. So the stability is come from the lateral wall of the denture, okay? For example, let's imagine that you have a high wall and then you placed something on it, this high wall will prevent it from moving right or left. But if it is a short wall, like this high wall, and then you place مثلا denture above of it like this, it won't resist it from moving, right? So this wall will give me the stability or resistance from movement. Okay, so when you treat a patient who recently extracted their teeth, it's recommended to wait till bone resorption happen, like 3 to 6 months we wait, okay? If you do it too early, the bone will change fast and then the denture won't fit and you have to make a new denture. In the next year, inshallah, in third year, when you have to bring a complete denture patient, you have to ask them, when did you extract your last tooth? فلازم he extract minimum from 3 months, okay? If it's less, I mean, he told you like I extracted my last tooth from 1 month, no, you can't accept this patient because the process of resorption is still fast. And if you made a denture after مثلا 3 months or 6 months, الridge, all of it will change وما رح يصير فيه فت, okay? I told you this information before. In the retromolar pad, it's occur when you extract the last tooth. تمام. Okay, so the maxilla anterior alveolar ridge is proclined, right? So the resorption of the ridge creates a smaller maxillary base. What's the meaning of that? Let's demonstrate it on blank page here. So if I have this and this is the maxilla, like this, okay? And let's have here the mandible. As we know that the maxilla, it's more proclined than the mandible, right? The maxilla is proclined at the mandible. انتوا بتعرفوا انه central incisors, the upper central incisors are in front of the lower, right? So this is the meaning of the first sentence. The maxillary anterior alveolar is proclined. Now, the resorption of the ridge the resorption of the maxilla happen in the anterior part of the crest, making the maxillary smaller, so it will become smaller, shorter, and narrower. What's the meaning of that? Let's imagine that this is the maxilla. We said that there will happen resorption of the bone, right? And we call this the resorption pattern. We are talking about that resorption pattern. Okay, so the resorption of the maxilla will happen from here, of course, and from this side, and it will happen like this, so it becomes shorter, and of course it will happen at another place from the anterior region, from here. So the maxilla will become smaller, shorter, and narrower, okay, from the anterior place. Okay, if we looked from it coronally, يعني إذا تخيلنا هاي هي المmaxilla, and we looked from it coronally, هاي هي المmaxilla, okay? So the resorption will happen from here, from the labial, the buccal side, from the anterior. So the maxilla will get what? Get like this. Will get narrower, okay? Will get narrower. تفهمين علي يعني بغض النظر عن سوء الرسم. It will get narrower like this because the resorption is happening from the anterior region, and of course it's happening from the occlusal surface, and if we looked from the sagittal we will see the maxilla as I was drawing it like this. So it will happen from the anterior region, so it will get also narrower from here and shorter from here, okay? So here's another picture to demonstrate it. If we looked from the here from the coronal part, so you can see that the maxilla is getting what? Shorter. What's this? Whatever. It's getting it's getting shorter because Ya Allah. No, because the resorption is happening in this direction. From it was this whatever the color, yellow, pink, or purple, and then it become the blue one. Look, it's become shorter, and looking from the anterior is also becoming narrower because the resorption is happening like this from the anterior side. Okay, so it's getting, if we compare this one to this one, it's getting narrower and smaller. Okay, now moving to the mandible. The mandible resorption, it will happen from here also, so it's becoming shorter, but it will happen from the lingual side, from the inside. So if it happened from the inside, it will get wider. So the opposite of the maxilla, it will get like this, wider. it's becoming wider from the inside, and from here it's getting short. تمام. So if we looked like this from the coronal, or like this, and imagine this is the mandible, so the resorption is happening from this side, from the inside, so it's getting wider, so it's becoming like this, it's becoming wider. Okay, لو we imagine that the tongue is here, the tongue is having more space, wider. Okay, تمام. I said the mandible dentition is positioned, whatever, I will come back to this. Okay, now let's go to this demonstration here. So as we can see here, the mandible is getting shorter, and it's getting, from here the resorption is happening, so it's getting wider. Okay, from the lingual side. Look here, it's getting, if we imagined it like a triangle, the triangle is getting shorter, and from here, so it's becoming wider and wider. Okay, تمام. So هلا what is this related للdenture أو للdentistry, أو when we press a denture. هلا when we want to press a teeth, okay, let's imagine that we want now to place a teeth again. So where is the place of the teeth? The place of the teeth, it must be, يعني we must put them back to their original place. We must put them back to their position before the extraction. So let's imagine that this is the maxilla and this is the mandible. So the teeth of the maxilla were here, this is the teeth, and then resorption happened, right? And the teeth resorbed like this. Now the new jaw is like this. No, I want to place the teeth where I want to place the teeth. Now I want them to place in their original space here, so I must place them more buccally. بنحطهم بالمكان that the resorption happened, so as to place them back to the place where the resorption happened. And the opposite is the mandible, because the mandible resorbed from the lingual side, so I have to place the teeth more lingual to their original place. And this is what is written here, that we need to place the teeth more buccal بالmaxilla, putting them in the correct position, more natural. In the mandible, the dentition, the teeth are placed lingually, okay, because the resorption happened lingually. Okay, that the denture bearing area now is more buccal, يعني it's moved more buccal, it's getting wider and flat and wider. Okay, so the resorption that's happened in the mandible is outward positioning. So the mandible got wider and it's like outward, it's moving outward, because as we said, the resorption is happening from this side. So it's moving like outward, but from the maxilla, it's moving inward because the resorption happening from this side. So it's getting smaller and inward. Okay, this movement, because of them both, yani this movement of the maxilla is getting inward and the mandible is getting outward, will create what? Will create the broganthic appearance, right? Will create the broganthic appearance that we talked about in the first lecture, that the patient will have like a witch chin, remember? Okay. That's all. So, moving to the hard palate. We said here, if we go back to our on figure, we are now talking about the stress or supporting area. We talked at the secondary here residual ridge. Now we are going to talk about the hard palate in the primary. Okay, now we are going to talk about the hard palate in the primary supporting area. So as we said, the hard palate is a primary stress bearing area. And what are the qualities that make it, or the feature that make it a primary stress bearing area? First of all, we will look at the bone. So the bone here, it's a good quality of bone we have in the hard palate. If we look at its anatomical, it consists of two bone. So the hard palate consists of two bone. It consists of the maxillary, the palatine process of the maxilla. So the maxilla, the palatine process of the maxilla, and the palatine bone. It's named the palatine bone. Okay, the palatine bone. So it consists of two bone, and these both bone are cortical. So we have a good quality of bone. So it's made of two palatine process of the maxilla and the palatine bone. This is the foundation, provides surface and support. تمام. هلا the hard palate, if you look at it, it's like horizontal. It's like a shelf. Now, when you any force that is acted on it, it will act perpendicular, because look at this. Here is the teeth. If you chew on the teeth, the force will go to the hard palate in a perpendicular shape like this. This is the hard palate, this is the teeth. The force will come into the hard palate in perpendicular way, and that will provide more resistance, more durability, more support. Okay, so we finished at the bone. The bone is a good quality. Second of all, we have keratinized or not. We said before that only two parts of the mouth is keratinized. It's the hard palate and the gingiva. So it is covered, it's keratinized. So keratinized. Okay. Now, according to third thing, you remember we talked about the thickness of the submucosa. He told you that the thickness of the submucosa is vary according to the place. It's varying according to the place. For example, if we go to the median palatine suture or the median palatine raphe, the median palatine raphe, it's the same name. Okay, the median palatine raphe is this, the line in the middle. So this is the median palatine raphe. The submucosa here is thin. Because it's thin, it's not resilient, it doesn't tolerate the load, it's easily traumatized, so we have to make relief. And we remember relief means creating a space. Whenever you see thin mucosa, then we are going to do relief. So this is important. Whenever you see thin mucosa, you are going to do relief. Okay, so not all the hard palate is considered of a primary stress bearing area. We have مثلا mid palatine suture is thin, so we have to do here relief. Okay, it's not a primary stress bearing area. Okay, the denture should not contact with this area. We have to create a space. Also, we have the ruga area here. You know the ruga area, right? So the ruga area here also have thin submucosa, and we have to do relief, and we considered it as a secondary stress bearing area, if you remember. Now we'll talk about it more. Okay, now on the either side of the raphe, like this is the hard palate, and here's the raphe. On the either side of the raphe, in the anterior region, we will have adipose tissue. Which is the oil gland, okay? And in the posterior part, we will have the salivary gland, okay? We will have in the posterior area here, salivary gland. So the composition also, difference, okay? So which area will provide the support? If we said this part is the ruga area, doesn't provide support, and here we have the soft palate, so no support, and in the middle we have a mid palatine area, so no support. So where is the support? It's come from just this, the horizontal part here and here. Even here on the ridge we have slopes here. So if you put or if you get support from here, it will be slippery. رح يكون هيك زي بزحلق إنه imagine a hill. So this part of the hill will become slippery. بزحلق. Okay, slope. So it's not categorized as a primary supporting area. So it's the support is come just from here as demonstrated in this picture, the horizontal part of it here. تمام. Now moving to the rugae area. Okay, if we went here back to our demonstration, the rugae area is situated here, is a secondary stress bearing area, rugae. Right, rugae area. Okay, so the rugae area, talking about it, the rugae on the mucosa on the anterior third of the palate. So it is the part, the anterior third of the palate. So it is this part, the anterior part of the palate, like this here. Okay, tamam. It consists of raised and depressed area. As you can see, it's like a mountain, raised or a valley, then like this. Okay. It participates. What's the function of the rugae area? Why God created it? ليش الله خلق لنا إياه? It's participate in the speech. لأنه الناس بيحطوا لسانهم. You place your tongue in this area to pronounce some letters. بعض الأحرف نحتاج نحط لساننا هون. And كمان مهمة بالsuction in children. When children اللي هن احنا عم نحكي عن الرضع يعني. Okay. Infants, when they suck the milk, they put their tongue there, so it's help in the suction. It is a secondary supporting area, as we said. Why? Because it is secondary because it has thin mucosa. Okay, thin mucosa. Also, the second reason, يعني it has thin mucosa. This is a reason, and the second reason because the palate is set at an angle on the residual ridge. So here because يعني بتلاقي هون إنه يعني this is hard palate. At the anterior region, you can see that there is an angle like this between the ridge and the hard palate. Okay, بيكون بهاي المنطقة like a slope. Okay. So it's not a good supporting area. تمام. Talking about the incisive papilla, these numbers that are here, they are the same number on the picture here. So if you can see, number 12 is here. So this is the incisive papilla. Okay. On this picture, if I can make it bigger. On this picture, the incisive papilla, it's like the picture on the left. So the incisive papilla is here. Okay. تمام. So الانسايزيف papilla it's the mucosa or the submucosa that is, so the mucosa that is covering the incisive papilla, okay, and the nasopalatine canal contain the nasopalatine vessels and nerves. So the incisive papilla, what's the meaning of papilla? Papilla means the submucosa or the mucosa, okay? It is a mucosa that is covering the incisive canal or the nasopalatine canal. So incisive canal, it's the same as the nasopalatine canal, okay? Why it's called nasopalatine canal? Because it contains the nasopalatine vessels, blood vessels, and nerve. So I have to protect these nerves and vessels. I don't want a pressure on it, okay? So what I'm going to do, I'm going to relieve it, right? Avoid impinging. I don't want any pressure on them. تمام? Okay, it's important, very important, because when resorption happen, it stay in its place, okay? Before and after the patient become edentulous, and it's like a reference point. So if you want to place the incisors back to its place, so it's located at a line behind or between the two incisors, okay? And it gives indication of the amount of resorption, it stay in its place. For example, I think that I have picture for this. Here, look at the incisive papilla. There is a constant space between, or distance between the incisive papilla and the teeth. We will talk about this later, but from the incisive papilla, if we imagine this is the incisive papilla and these are the teeth, you can see that the space between the incisive papilla and the teeth, it's around 8 to 10 millimeter. So when you want to place the teeth more, you can know where I have to place. So this is هاي أهمية landmark. Here you can see what is the importance of knowing these landmarks, because when we want to place the teeth back, it acts like reference. It's like at reference point. It gives us the marks where to place the teeth, okay? تمام. فهي شوفي incisive papilla come between the two central incisor behind them, and the space between them is constant. Even if resorption happen, the incisive papilla won't resorb, so it acts like a reference point, okay? تمام. بعدين في عنا tuberosity. Talking about the tuberosity, do you remember the tuberosity? We said here that the tuberosity is a primary stress bearing area, only tuberosity, but we say it must be what? Firm. It must be firm. So it must be dense. If it is dense fibrous, so it's a primary supporting area when it is dense, when the connective tissue is dense, not loose, okay, with minimal compressibility, and it's firm, okay. Let's see picture here. So if there is no opposing teeth, okay, if we extracted the lower teeth, okay, hypertrophy will happen to the tuberosity, as we see in the picture on the left. It will enlarge, it will become bigger and bigger, so it will interfere with the denture. So the patient lose the mandibular teeth, tuberosity will grow in size, making the area, if this is the maxilla and the tuberosity grow in size, and this is the mandible, so there is no place for the mandibular teeth to be placed, affect the size of the teeth that need to be put. So we have to remove it surgically. So we are going to cut it and remove it like this surgically, okay? So we want to create a space. Okay, so sometimes if it's really enlarged, we have to take into consideration the surgical removal of it. Okay, now we have the teres palatinus. We talked about the teres palatinus. It's something that we need to do relief for it, right? We talked about it here in the relief part. That we need to do for the palatal teres and median palatine raphe and the incisive papilla, all of them, they need relief, okay? So the teres palatinus, this is the teres palatinus, and we will talk about it now. So it is hard bony enlargement. It's like, in simple word, extra bone. So they are bone that are enlarged in this area. It happened in the midline of the roof of the mouth, and it happened in the midline of the hard palate. This is the hard palate. In the midline, we can see on extra bone or bony enlargement. It's come in different sizes. It can be very small, and it's different shapes. It can be flat, like this picture. It can be lobular, multiple. It can be spindle هيك هذا الشكل, okay, and it can be nodular, like a node, like cake, مثل الحبة, okay. It is covered, this is the important part, it is covered by thin layer of mucosa, because if it's thin, I told you, when you see thin, you are going to do what? Relief. So it is traumatized easily, so relief it's need relief. It's a secondary stress bearing area. It needs space. It needs relief. If the torus extend posterior, يعني if the torus is very 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 big and it's extend posterior كتير, so we have to remove it. We have to do surgical reduced and to achieve the posterior palatal seal and retention. We will talk about this word later on. Okay, so not thin mucosa mean relief. So if it extend posterior to the vibrating line, we will talk about the vibrating line in next pages. I need to remove it to achieve posterior palatal seal. Put in mind these words because we are going to talk about them. Retention, we already talked about it. It's the resistance to be what? Fall or displaced, right? So we are going to take this new word later on. Now, we finished the supporting part. We are going to talk about the bearing area, the supporting. We finished this. Now we are going to talk about the peripheral, the limiting areas. Okay, so in the maxilla, this is all about the maxilla. We didn't mention the mandible. Okay, so now the peripheral border, the limiting structure, we have first the labial vestibule. تعرفوا شو يعني الvestibule? Vestibule is like the pockets of our mouth. Like if you place your finger between your teeth and gingiva or between your lips or between your cheek, you will find that there is like this, like a pocket, right? There is a pocket. This pocket is called the vestibule. So the vestibule, we have labial vestibule and we have buccal vestibule. Okay, so we have two vestibule, labial vestibule and buccal vestibule. Okay, and we mentioned here what's the meaning of vestibule. Here is the vestibule. Okay, so the labial vestibule, it runs from one buccal frenum to the another buccal frenum. Okay, so it's run from the buccal frenum to the another one. Okay, and in the labial side. So this is the labial vestibule. Here it is the labial vestibule. تمام. It's divided into left and right by labial frenum. So we have buccal frenum, labial frenum. We have buccal vestibule, labial vestibule. This is the labial frenum. This is the labial frenum. It divides the labial vestibule into right, here right labial vestibule, and we have here the left buccal, the left labial vestibule. And the labial vestibule will end where? It will end here. Look, this is the buccal vestibule. This is a buccal vestibule. This is a labial. So we have here right labial, left labial, and all of this is the labial. It ends here. Okay. This is the labial vestibule. Okay. Now, what is the labial frenum? The labial frenum starts superiorly as a fan shape. Like if you see this picture, it starts superiorly as a fan shape and convert it descend to terminal attachment at the labial side. So like from here, it starts like a fan shape, like this, like زي المروحة. And when it descends, it converge, يعني it's merge, يعني بتتحد, it's merge, okay, and then they become like one and attached here in the labial part here, okay. So it starts like a fan-shaped fan, زي المروحة, and then they merge to reach the labial side of the ridge. Okay, it contains no muscle. It has no action of its own. So what's the importance of the labial frenum? The labial frenum moves when the muscle moves. Like when we have the orbicularis oris muscle. This is the orbicularis oris muscle. This the muscle that's in circle. Okay, and we have the zygomatic major and minor muscles. This is the zygomatic major and minor muscles. Okay, you can see them, and if you can go to Google and see them more. And a clearer picture for them. You took them already in anatomy. And you have the buccinator muscle also. We have here the buccinator muscle. So when this muscle contract or when the muscle are in action, the labial frenum will be moved, okay? So to accommodate this movement, because this labial frenum will be moved, we are going to make in the denture like a notch, like a space for it to accommodate its movement. So we'll make a notch to accommodate its movement. We are going to make a notch of the denture for the frenum. If we didn't make a notch, إذا كانت هيك الطقم مسكر عليها, if the denture is occluding in it, an ulcer may be happen, or the denture will get out of its place. يعني when it move, it will make the denture fall down, okay? Or it will create an ulcer. So always you have to do a space for it to accommodate the movement عشان أخليها تتحرك بأريحيتها, okay? Now we have the buccal frenum. The buccal frenum are here in the picture, okay, or here, as you see. So it's also Okay, it's the dividing line between the labial and buccal vestibule. As I said, we have labial and buccal vestibule. The dividing line is the buccal frenum. It can be single or it can be double. And even it can be its broad. Yani, we can have one just buccal vestibule or we can have two next to each other, double buccal vestibule. And they are bigger, they are broad fan shape, okay? Here, why they are bigger and why we have to do the relief here or the notch now. notch هي الفتحة اللي أنا عملتها على الدنشر هي النotch. The notch one must be bigger for the buccal vestibule. Why? Because the orbicularis oris, the muscle that we talked about, it will pull the frenum forward and the buccinator will pull it backward, so it will move more. So the movement of the buccal frenum is more than the movement of the labial frenum. So when I make a relief, when I make a notch or a space for it, the space must be bigger, okay? For example, when you say O, the buccal frenum will move where? Forward. And when you say E, with the buccal will move backwards, and this needs more space so it can move. If we didn't create this space, what will happen? Ulcer. If no ulcer happen, the denture will fall. يا بفوقع يا بصير ulcer. So it's wider than the labial one, because it has wider range of movement. تمام. هلا الbuccal vestibule, it lies like behind the buccal frenum. It extends from the buccal frenum to the hamular notch. Okay, it lies opposite the tuberosity. Here is the labial vestibule. Sorry, buccal vestibule. It's from the buccal frenum until the hamular notch. This is the hamular notch, and now we are going to talk about that. Okay, so creation of the contraction, sorry. Okay, so هلا buccal vestibule size is changing. Okay, so this buccal vestibule size we're going to change. It change because of multiple things. First of all, the concentration of the buccinator muscles. If you say O, try to say O, هتلاقوا إنه هيك خدكم انفعص صح؟ You will see that your cheek are coming هيك together. So the space, okay, or when smile, okay, the size of vestibule will decrease, right? So when the buccinator muscle is in action, contract like O or smiling, the size will decrease of the vestibule. Another thing that make the size of the vestibule change is the position of the mandible or the coronoid process. You know the coronoid process, like this picture. We have the condyle and in front of it the coronoid process in the red. Now when you open your mouth or when you smile or you open your mouth, the coronoid process will move anteriorly. Look of this coronoid process moved anteriorly, it will become near the teeth. يعني هاي الcondyle and this is the coronoid. Okay, if you open, this is the condyle and this is the coronoid. Now if you open your mouth, this coronoid will move next to the teeth. You can see here the teeth. It will go closely to the teeth. So if it come close to the teeth, it will impinge on the vestibule. So the vestibule will become what? Decrease. Okay, it will decrease in the size. Okay, so now also if you coronoid process play a role in the size of the buccal vestibule. So we have buccinator muscles and the coronoid process. Also now the bone loss from the maxilla. So as the resorption of the bone increase, the depth of the vestibule decrease. Like for example, this is the ridge and this is the vestibule. Now if the resorption increase, look, the depth of the vestibule will decrease, right? Again, this is the ridge and this is the vestibule. Now if we want to measure the depth is from here until here. This is the depth. Now if the resorption increased, what will happen to the depth? The depth will decrease, right? Now the depth is just from here to here, so the vestibular depth will decrease. Okay, the depth should be taken into consideration when we make the denture. Now distal to the buccal frenum, distal يعني posterior to it, we have and palpable posterior to it, superior to it. So if you go posteriorly and superiorly up and you touch there, you will feel the zygoma. You will feel a bone is called zygoma. It's located opposite above the first molar, it's here. This is the zygoma اللي هي عظمة الخد. So if you go posteriorly and up يعني opposite, superior to the first molar region, you can touch the zygoma. Okay, so in this picture, look how it's high zygoma that's pointed it in the arrows. High zygoma that is كتير مبينة white بالpicture. This is the zygoma. Now, if هلا الزيغوما as you see here is far away from the teeth, but when the teeth is extracted and resorption will happen, it will become very close. So we need, when an extensive resorption happen, we need to do relief. Okay, so for example, again, if we have, here's the teeth, and here is, for example, the zygoma. So they are far away. But when these teeth are extracted, then the zygoma will become near the ridge. So if extensive resorption happen, like this, so we will become next to it. So we have to do relief, okay, because they are bone, and it's bone. Tamam. Now moving to the hamular notch. Here we are continuing talking about the landmarks in the maxilla. We already talked about this picture. I know it's not clear, but we talked about this area, which is the incisive papilla. We talked about this area, which is the rugae area. We talked about this area, which is the alveolar ridge. We talked about this area, which is what? Which is the tuberosity. We talked about here the labial vestibule, the frenum, the buccal frenum, and the buccal vestibule. Okay, we talked about this, the mid-palatine raphe. Tamam. So we are now going to talk about this part, which is the hamular notch, I think, right? So now talking about the hamular notch from its name. Notch يعني something that's depressed inside. So it's the distal limit of the buccal vestibule. It's the limit of the distal. We said that the buccal vestibule from the buccal frenum to the notch, right? To the notch. So it is the distal limit of our denture and the distal limit of our of the buccal vestibule. Okay. So the end, if they ask you in the exam, what is the distal limit of your denture? Yani where the denture end distally? It's end distally at the hamular notch. Okay, so it's situated between the tuberosity and the hamulus of the median pterygoid plate. So between the tuberosity and the pterygoid hamulus. This is the pterygoid hamulus, as you can see in the red. This is the pterygoid hamulus. So it's located between them. As you can see in the picture, we have like this, and this you have the hamulus. So this that is located between them here. This is the hamular notch. Okay. Okay. If you placed a mirror, a dental mirror of course, a mouth mirror, or a T-shaped burnisher اللي هي الأدوات البرنشر اللي بتلمع that you use it in cons, if you place it in that plate, you can feel that notch. You can feel the depression there, like this, right? The mirror can feel the depression right there. Tamam. So, why it is important? The mucous membrane of the hamular notch is thick, like thick mucosa. And it's made of loose areolar tissue. It's compressible. It's compressible. Okay. طيب, what's the important if it is compressible? We need it to achieve the peripheral seal. What's the meaning of peripheral seal? Okay. Let's imagine this is a bottle. هلا how you close the bottle? يعني كيف نحن بنسكر القنينة كتير منيح. How you close it? By ال cover of it. It have to be to make a seal. صح؟ لازم تسكر منيح. So nothing is filled of the bottle, right? يعني هاي لو أنا عندي قنينة. This is a bottle and I want to close this bottle. Then I have to place a cover and the cover have to seal it properly, right? Close it from all its sides. Okay? So nothing of the bottle will what? Will drop or will be lost. Okay, now this will apply to the denture. If this is my denture, this is the maxilla. Okay, this is the maxilla. Then when I want to put my my denture, I want to fit and close around it properly, so it's make a seal, so it's close it, so it's yani hold it, fit it. So why I need this seal? To achieve the retention. I want this seal so the denture will not fall down. Okay? Okay. So we want, we will use now this limiting, هدول limiting structure that we are talking about them. These limiting structure that we start talking about them. The peripheral border of the tissue, the limiting structure will help me of getting the peripheral seal. They will help me by getting the peripheral seal. In this place, I will make the notch and I will extend my denture here. Then, in this area, of course, in the buccal, also I will make a notch and then I will continue extending. This is the notch for the buccal, extending my denture. Now the distal limit or the last limit of my denture is here at the hamular notch, and we will make the denture enter this area because it's compressible. لأنه هي منطقة مضغوطة، أنا فيني أضغط الطقم هناك وتعطيني هيك زي لوك، خلص هاي السيل and the retention. Okay. تمام. And it's important also because here we have the picture here we have the trigomandibular fold or raphe, the trigomandibular raphe. So you have the trigomandibular raphe. It is in this place, the trigomandibular. It's connected between the hamular notch and the retromolar area inferior, retromolar pad of the mandible. So it's extend from hamular to the retromolar pad. This area, it's movable. It's move forward when you open your mouth. So if you extend، أنا إذا مديت الطقم كتير 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 لورا وخبط بهاي الرافة رح يصير الطقم يوقع. So I have to know where to extend my denture. As I said, that the distal extension or the distal limit is to the hamular notch. If you extend it far posteriorly, you will hit this trigomandibular raphe. كل ما المريض every time the patient open his mouth, the raphe will move forward. So the denture, what will happen? The denture, it will fall down. Okay, the denture will fall down. There is no retention. If it doesn't fall down, it will cause trauma or ulcer. وصلت؟ So أنا بعد هاي الهاميلر نوتش في عندي رافي قاعد ورا. إذا أنا مديت الطقم للرافي كل ما أفتح تمي ويتحرك رح يوقع. إذا ما وقع لأنه كتير ماسك منيح بيكون بيسوي تروما أو ulcer. تمام؟ هلا let's talk about something. It is vibrating line. حكينا هون رح نحكي عنه. I told you like remember these words. We are going to talk about them in a few minutes. اللي هن هون. This is now we talked about the palatal seal or the posterior palatal. Now we are going to talk about the vibrating line. Or we didn't talk about the palatal seal, but it's the same concept of the peripheral seal. From the sides, يعني this is maxilla. From the side, I can achieve the peripheral seal. From the posterior part, the palatal part, I can achieve the posterior palatal seal. Now, when you want to close a bottle, this is the bottle, and you want to close it, you have to close it from all the sides. If it's broken from here, then the water will exit from here, right? So as the denture, I want to close it from all the sides. From here, it's called the peripheral seal. Okay, from the posterior part, it's called the palatal seal. I want to close it from all the sides. تمام. So now, as I said, from the edges or from the peripheral part, we have what? From the peripheral part, we had the labial vestibule, we have the buccal vestibule, we have here the hamular notch. Okay, so from this side, from the palatal side, what do I have to achieve the seal? How can I achieve the seal in this place? There is nothing to hold. صح؟ يعني looking at your heart palate. If I want to close it, I can close it here from the labial side, then buccal side, then the hamular notch, and like this. I can hold this. But here, what do I have to hold? Okay, so we will create something to achieve the palatal seal. This thing that we are going to create it is based on the vibrating line. So what is the vibrating line? The vibrating line, it's an imaginary line that we will draw it based on some anatomical landmark. So this imaginary line, it's the junction between the movable and non-movable of the soft palate. Important. It's not related to the hard palate. So we have here the hard palate, and then a line. This is the soft palate. Now, inside the soft palate, we have also two parts. We have movable and non-movable part. This is the non-movable part. The non-movable part is anterior because it's close to the hard palate. And we have the movable part posteriorly. Now, the line here between the movable and non-movable part of the soft palate is the vibrating line. تمام? Now the tissue that is anterior to this line, and the tissue in this area, in the non-movable part, are compressible. So we will achieve the palatal seal or the retention or the peripheral seal from this tissue, from this tissue. تمام? Okay. هلا, forget what is written here. I will read everything is written here, but I want to explain for you what is the vibrating line. Okay. تمام. هلا as I said this is the hard palate and we have here a line. This is the soft palate. Now between the hard palate and between the soft palate, the two parts, we have non-movable and we have movable part, okay, in the soft palate. Now the line is here between the movable and non-movable soft palate, in the soft palate, okay. So how can I draw this line or define this line? There is two ways to define this line. One way is to tell the patient to say the patient بصير يحكي so when the patient say this movable part will drop down, رح يتحرك لتحت. So when it drop down, I can draw this line. The second way is to draw it according to anatomy. هلا drawing this line according to anatomy, it extend. This line anatomical, it extend from the hamular notch to the hamular notch, anterior to the fovea palatini, anterior to the two fovea palatini. What is the fovea palatini طيب? The fovea palatini are two depression on the posterior aspect of the soft palate. So they are situated in the soft palate. They are two depression. Okay, what are these depression? It's the coalescence of a mucus gland duct. It's the opening of the mucus gland duct, like this picture. Look, it's the opening of two mucus or مش two, of multiple mucus gland duct. It's two opening, okay? Usually it's located 1 or 2 millimeters posterior to the vibrating line. So the vibrating line is anterior to it. The denture shouldn't cover it, تمام? Why the denture shouldn't cover it? If the denture cover it, then the mucus will accumulate under the denture. يعني لو غطيناهم السلايفا رح تتجمع تحت الطعم. فأنا ما بدي cover it. I don't want to cover it. I want the denture to become anterior to it. قدامها. ليش بدي الطعم يجي قدامها؟ عشان ما بدي السلايفا. I don't want the saliva to accumulate under the denture. تمام? Now the distance from the vibrating line may vary. But they are always يعني some patient will have the line anterior to it 1 to 2 ممكن أكتر. It's vary. Now going back to how we draw, وصلنا شيء الفوفيا palatini. So the fovea palatini are two opening. They are the opening of mucus gland. Now drawing the vibrating line. The vibrating line from the hamular notch from here. Then the hamular notch will draw anterior to the fovea palatini and going back. Okay, like this. So if you want to draw it, we have two ways. We can draw it based on this anatomical feature, as we said, from this hamular notch to the hamular notch, anterior to the fovea palatini. Or the second way is to tell the patient to say لما البيشنت يحكي this the movable part will go down. When it go down, you can draw the line, or you can use the two methods together. فيك تستخدموا الطريقتين مع بعض. هلا now after you define this line, يعني after I drew the line, I specified the line. Okay, نعتبر إنه I have drawn the line by either the method, okay, that I wanted. So we draw the line. Now after drawing the line, we said that this part, this area that is non-movable, that is anterior to the line, is compressible. So this area, this whole area, I will use it to create the palatal seal. After drawing the line, we will use this area to create the palatal seal. تمام. I have picture here. Look, the yellow line is the junction between the hard and soft palate, and the black line is the vibrating line that we created. Now the red line that's between them, it's the area, the compressible area, the whole area that I'm going to use it to create the seal. Okay, so that's why here they are telling you that the vibrating line is more like an area and always on the soft palate. تمام. So the lateral border of it, it's end at the hamular notch, because we said from the hamular notch, and at the midline, it's 1 to 2 anterior to the fovea palatini. Okay, so the distal end of the denture, of your denture, the distal end must finish at the hamular notch and the vibrating line. So this is your posterior end or distal end. I told you before the distal end is the hamular notch. Of course it's right. The hamular notch زائد the vibrating line that we have now drawn or specified. Okay, that's why. Okay, and the soft palate start vibrating when the person speak. So as I said, the soft palate or the movable part of the soft palate, when you speak, it will like vibrate, it will start moving. Okay, so if the vibration, if you extend, what will happen if I extend the denture posterior? If I extend my denture posterior to this line, yani if I created my denture like this, what will happen? When the patient speaks, this part will vibrate. If the vibration is very strong, the denture will move and will fall down. And if the vibration is weak, but there is vibration, ulcer will happen. Ulcer will happen. زائد to add in addition الفوفيا palatini, as we said, the mucus will accumulate under the denture because you are covering it in this case. Okay, that's why in the teres palatinus, going back to the teres palatinus, we said here that if the teres palatinus extend posteriorly to the vibrating line, and posterior to the vibrating line, you have to remove it because if it extends, how can I create my denture? Okay, because I want to achieve the seal. Okay, that's all, I think, right? Yeah. Okay, so my denture has to end as the vibrating line and as I said, anterior to the foveal palatine. Now, to take home message, to maximize the success, as I said, and as we said at the first lecture, look, the success is between. To maximize the success, we have to fulfill the retention, the support, and the stability. تمام. Understanding the structure and the function of the anatomical landmark. As we said, if we studied each anatomical landmark, it will give me an important role in the complete denture treatments and in the health and disease of the patient, because each landmark, as we said, for example, here, we learned about the foveal palatini. Now, because we know what's the foveal palatini and what's the function, we know that the denture must be anterior to it, so the mucosa, the mucus, gland, or the salivary will not accumulate under it. So studying each component alone will give me the importance, and I know how it's related to the denture. So we have to relate the anatomy to the function, and we want to this anatomy and this function to integrate it to the practice, to my clinical practice, to my treatments. Okay, that's it. Any question? I'm welcome, more than welcome to answer it. وبس هيك، أي إشي شايفينه لساته مو كتير واضح vague, you can ask me. Anything is not clear enough, you can ask me. And even if you are curious to know more about anything, I'm more than welcome to answer. يعطيكم العافية.